Hello and welcome to another Ask WHO Live, coming to you from a few different places today. The topic is monkeypox. We've done this before. We're doing it again. Today we've got three people with us. From WHO, we have Dr. Rosamund Lewis, who's our technical lead on monkeypox. We also have Mr. Andrew Seale, the WHO expert on HIV, hepatitis, and sexually transmitted infections. He's in Montreal at the AIDS 2022 conference, as well as our next guest, Dr. Keletso Makofane. He's a fellow at the FXB Center for Health and Human Rights at Harvard University. He's a public health researcher and activist who works on global HIV response. Welcome to all three of you. Thank you for joining us.
Thanks.
Thank you.
Thanks. So we're going to start off talking about the public health emergency of international concern. So a couple of weeks ago, the Director General convened for the second time the Emergency Committee. These are global experts who were brought together to advise WHO on monkeypox and asked them for their view on whether or not this situation constituted a public health emergency. I'll hand to you first, Rosamund. The Director General did declare a public health emergency. What has that meant? What has changed? Even just speaking about your own work, what has changed in the last few weeks since we declared the emergency?
Thanks, Nika. I've actually seen a significant change in the level of attention being paid to this outbreak right now, in particular in terms of raising awareness. So there's been a real upswing in interest from media, from social media, from journalists. So the raising awareness and on the one hand for people who may be at risk and communities in general, and also trying to answer questions about this outbreak. I've seen that response is the most important response. I've also seen countries activate their response.
I think that has been key. I know that I'm lucky enough to sit on the morning updates from our emergencies colleagues, and definitely countries are reaching out more, asking more questions, asking about access to the tools, the tests, the therapeutics, the vaccines, and so on. Andy, we were just chatting before we started this live. You were at the AIDS 2022 conference in Montreal, and you were saying you've heard some feedback from there. What are people saying at the conference about the declaration of the emergency?
Thanks, Nika. Well, we had a very good session in the symposium, a technical session yesterday. And we've had a number of community conversations, and Keletso has been involved in some of those. I think, first of all, there was recognition that from community at least, and also many of the scientists and clinicians who work very closely with communities, that there has been a feeling that this has been an emergency for some time. So I think there is appreciation that Tedros did call this an emergency, especially given the fact that it was quite a difficult emergency committee that met with very different concerns and perspectives being shared. And so it really was the Director General's call. So that I've heard appreciation for that call, and I've heard a request for more action now in response to that. But again, this conference came at really a critical moment, just pretty much after the designation of public health emergency of international concern. So we've had this unique opportunity where community and scientists come together to really reflect on the key issues affecting our communities at the moment. And monkeypox has definitely been one of the key issues discussed this week at this conference.
And Dr. Makofane, over to you. We also chatted a little bit before starting, and you think we were a bit slow, actually. WHO was a bit slow. Tell us more about that.
Yeah, so I do appreciate that the Director General, in a sense, overruled the committee and decided that based on what he was seeing, that this is a public health emergency of international concern. I think this has been obvious for some time, and the question has been who is going to make the first move and really make it clear to the rest of the global health community that monkeypox is a serious illness, and that the fact that it's rising in this population is not only dangerous for our health, it's dangerous for our lives in the context of the homophobic societies we live in across the world. So declaring a public health emergency is good in that it lends the gravitas of the World Health Organization to this set of issues, which is urgent, and it requires urgent action, which we have not been seeing. It would have been good for it to be earlier, but we're here now, and I think we should be thinking together about the core challenges of responding to monkeypox at this time.
Thank you. And we'll touch on more of that as we continue our conversation. I just wanted to remind everybody that if you want to ask us a question, you use hashtag AskWHO if you're on Twitter, if you're watching us from, or if you're following this from Twitter. If you're watching on Facebook, YouTube, or LinkedIn, you just put your question in the comments. And we have colleagues who are gathering the questions and will send them to us. And I receive them on my mobile, which is why you will see me glance down once in a while to look at my phone as well. So actually, I wanted to start with you, Andy, and I know people. WHO has been accused of being homophobic for saying that, for describing the situation and where we see that a majority of cases are in men, and the majority of cases for which we know a sexual orientation has been in men who have sex with men. Can you explain in the simplest language you can why it is that the disease is spreading in communities or networks of men who have sex with men, and what that means? Just explain it really simply first.
I'll do my best, and I'll try and do perhaps a simple response and then expand a little if you'll allow me. First of all, there are several modes of transmission. So there are different ways that people can become infected with monkeypox. It really, skin-to-skin contact is the most efficient way, especially if there is an exposed lesion. So a monkeypox lesion is the most efficient way of doing this. People can also have lesions that are hidden inside the mouth or inside and around their genitals. These might not be so obvious. So contact with those lesions essentially will lead to transmission. So kissing, skin-to-skin contact, and close intimacy. What we found is that, despite the fact that that there are these several modes of transmission, it seems to be very efficiently passed on through sexual activity. And this sexual activity could have been with any group of people, but it's found its way into networks of people who are connected because they are having, because it is sex between men essentially. So bisexual, gay men, other men who have sex with men are at the moment mostly affected. So we're seeing figures from Europe and elsewhere that 99% of cases are within this group. Now that doesn't mean that this is in any way a disease that is just for that community. So we absolutely have to separate out the community and the action, if you will, so the behavior. And already we're seeing for some time, we've seen communities taking great leadership in helping get messages across around prevention and really trying to be on top of this response. It's really important that we balance our messages. So we have heard this, as you say, we have been asked about, is it homophobic to expressly describe what we're seeing? The answer is no. We need to direct resources to where we're seeing cases, and at the moment it's in those communities that we've heard. We've also heard at this conference that we need to slightly expand our understanding and definitions to also include some trans people who are also within that sexual network. So we will be doing that, and communities are already doing that with their outreach. So in short, it's a virus. Viruses can affect anybody. Viruses tend to have more than one way of transmitting. At the moment, as I say, it seems to be most efficiently transmitted through sexual contact and within the group that we're targeting. We're working very closely with communities to make sure our messaging is correct. Anika, I don't know if it's the right moment now to just talk a little bit about the key messages. I'm happy to do that, or we could come back to that later. I'm looking for some.
You know what? I can't cut away from you and not talk about the key messages.
All right,
so go ahead and give us the key messages, but then I'm going to come back to some of the other things you raised, and we have some questions as well. So go ahead, Andy, deliver our key messages.
All right. Well, so this is really about transmission. So if you have exposed lesions, you need to isolate until they've healed. And if you can't isolate within your household, for example, because it's just too difficult, you can't find that space, keep your lesions covered. And we have lots of advice on the website around home care. So follow that advice. We've got great advice on the website. Also, if you are from the community, and we spoke earlier, and you had a great example, we need to get messages to affected communities. Who are affected communities? It won't be all bisexual men. It won't be all men who have sex with men. One of the key things you can ask yourselves is, am I hearing about somebody I know or a friend of a friend, or is there a report in my local community news? That's the kind of thing that will give you a signal that the virus is closer to you than perhaps you might have thought. So you will be perhaps in a higher risk group if you are sexually active within that context. So if you are sexually active, really think through, weigh up your risks around how you manage your sex lives for the moment. So perhaps be thinking about reducing the number of partners you have, or asking yourself whether it's the right time to be going to saunas or clubs. And again, communities are best placed to be really helping with nuanced messaging here. WHO can provide the facts, and we work with communities, but really it's the communities themselves that will be heard by others and will be recognized as credible voices. Know the symptoms that you need to be looking for, and withdraw from social and sexual contact if you do develop symptoms, and get medical advice. And if vaccines are being offered in your community, certainly consider taking up that offer, but recognize, as I think Nika said earlier, that there is a time delay for protection. It seems to be very encouraging news, and I think the vaccine interest in vaccines is very high. Communities are really seeking to get these vaccines. And the final message would be really fight stigma. So there's a lot of misinformation out here. Let's calmly try and work with people to understand where they're coming from with their perspectives, point them in the direction of trusted information, and engage in conversations, because this is there's a lot of fear because there's a lot of unknowns at the moment, particularly outside of the affected communities, but we can all continue to talk to each other and share trusted information. Thanks, Nika.
Thanks, Andy. There's a lot of information. I know it's a lot to digest, and I don't think we expect our viewers to remember everything that's been said, but hopefully we've answered some questions that you have top of mind. Keep following WHO on Twitter, wherever you're watching us from. We're putting up content regularly. What's the advice in your country? What's the government saying? What is your local health authority saying? What are your peers and your colleagues saying, especially if you're within an affected community? So seek information where you can, and I know it's a lot to absorb and can be very confusing. We have a question here. I think I'll go to you, Rosamund. There's a Dr. Khan Aga on Facebook is asking, are there predisposing factors to monkeypox? But as Andy said, it can affect anybody. Anything else you want to add, Rosamund?
Yes, I can split that question into two parts. What are the predisposing factors to being at risk of exposure, of catching monkeypox? And then the second part is, what are the predisposing factors to having a severe course of illness, to being very unwell, as some people are. And so in terms of the exposure, I think Andy has really laid it out in terms of physical contact, face-to-face contact. People who have lesions in their mouth can spread it to others through kissing or through just talking at very close quarters. There may be, contact with bedding that is infected and things like that. So there are different ways that people can catch monkeypox, and the predisposing factors are really the activities. So the activities that put you in contact with others who may already be infected, which is why right now we're seeing it in one group that do have a lot of gatherings and a lot of social contact. But others can also catch it, as you said, Nika. Others can, for example, in the family setting, in the household setting. This is how monkeypox really began in Africa when it was first discovered there. It was coming from animals in the forest setting, for example, and then a hunter would bring food out for the family, but the family may have, touched a contaminated animal, or the meat may not have been fully cooked. And so it's possible in the family setting to be exposed to someone who has monkeypox. So there's many different settings where someone can be exposed to the virus or exposed to the disease, and they're all important. Every single one of these modes of transmission is important. What Andy has been saying is that right now we're seeing more cases in one group of people, and we're really trying to get information where it needs to go to that group of people as a priority. But everyone can assess the information, assess their own risk, and then reduce their own risk through the activities they choose to undertake. The second part is what are the predisposing factors to having severe illness is really important to appreciate that anyone who can be exposed to monkeypox, but also who has underlying immune compromising conditions. That could be people who are on immunosuppressive drugs like cancer treatments, chemotherapy, someone who may have HIV, but that's not fully treated and that's not adequately treated. So they may have some immune issues. Other people who have natural lower immunity, for example, children or persons who are pregnant who can also transmit the virus to their fetus, or the infant can be born with the virus. So there are some situations where people may have a risk of more severe disease because of their own health or their own situation, or even how they contracted the disease. So these are all really important factors.
Thanks, Rosamund. There's a number of questions on what the response is, whether there's a vaccine, whether the vaccine works. I think I'll come to you next, Dr. Makofane, this call anyways, as a representative of community and an advocate for community. What are people in the most affected groups asking for? What do they want the world to do better?
Yeah, I think I can say two things. One is also in relation to the question about, is it homophobic to point out that the community that has the highest burden at the moment includes gay and bi men and some trans people? I think that's the wrong question, and it's a question that I've heard repeated multiple times. The right question is it homophobic for there to be vaccines sitting in a freezer in Denmark and not being mobilized to stop people from getting monkeypox? Is that homophobic? Is it homophobic to not give people the opportunity to plan whether they can get vaccine or not? Is it homophobic to allow for providers to deny people access to medication, access to any kind of service, really, in the context of monkeypox? Those are the kind of homophobia questions that I think are what is driving the response and the epidemic that has formed as a result of the response. Had we taken action quickly enough, had we thought that the lives and the health of gay and bisexual men are important enough to get the vaccine out of the fridge and into our bodies, we might not be having this conversation at all. So my plea to people thinking about the role of homophobia in the monkeypox epidemic and response is to consider whether, if monkeypox had started among children in kindergartens across countries, we would still be weeks into the epidemic without a global plan of action. I think people should consider that. The second thing about talking about homophobia and having to speak with care about why the monkeypox outbreak is concentrated among men who have sex with men is really a question, a concern that people who are ordinary people don't understand the way that gay and bi men have sex, or that they don't understand why they have sex. They don't understand why they have group sex. They don't understand why they have sex if they know that sex bears some risk to their health and possibly their lives. And I think there are two ways to go about responding to this kind of concern. One is to try and explain what this culture is about, why people feel the need to connect, why in the context of a bigger epidemic that has forced us to be isolated after a whole life of isolation, why people might be more keen to connect than anyone else. You can try and explain that. I think you could make a useful case, or a good case, or good explanation for people who are not in this community. But ultimately, I think you don't need to understand that. You don't need to understand how and why people have sex. I don't understand why people play American football. It injures a lot of children. There are lots of neck injuries, head injuries that have serious consequences for their health through their adulthood. And they make those decisions when they're children, the decision to play or not. I don't understand why parents do that. I don't understand why children do that. But I don't have to understand to know that as a public health professional, I am duty bound to respond to their health problems. As a doctor, I'm duty bound to respond to their health problems. It doesn't matter ultimately what human being, whether you understand a human being or not. If someone is a person, and just like you are a person, and is standing in front of you saying, I'm experiencing the worst pain in my life, it doesn't matter whether you understand how or why they came to that pain. Your duty is to respond to it. And I think what has happened is that large institutions that we depend on to respond to our needs have failed us, have been slow, have waited to see whether this thing will disappear on its own, and have framed monkeypox as if it is not a serious illness. At the same time, I have been on the phone, on Twitter, with friends of mine who are suffering the worst pain of their lives, And they need help getting treatment because they were turned away by their doctor who couldn't or wouldn't spend all the time it takes to get them on treatment. So I think both the question of homophobia and the question of the response in general requires us to decide whether people that we don't understand deserve to be healthy and deserve to live or not. And I would like to live in a society where every person deserves things that dignify the person, dignify people's lives, and preserve health and preserve their ability to enjoy themselves. I think that's the goal that we should be going for. That's the reason I'm in public health.
Thank you, Dr. Makofane. I think you actually helped me understand some perspectives even in this chat. And I won't forget what you said about it doesn't matter if you understand or not, people still deserve the care. I wanted to hand it to you, Rosamund, because Dr. Makofane also mentioned that this is a serious illness. Of course, it causes incredible pain, but can also kill people. And that's something that sometimes people forget. So can you just tell us, we don't have confirmed figures yet, but tell us what we're hearing over the past few days. Tell us how many deaths there have been and what we're doing to find out, to get more information.
Yeah, thanks, Nika. And if I can, I'd like to actually also respond to what you've said, Keletso, which is about the dignity, the importance of dignity and human rights. And in the temporary recommendations that our Director General, Dr. Tedros, has issued to all WHO member states, the very first principle that's outlined in these temporary recommendations is that these are guidance for countries, but that all of these interventions and responses should be carried out with the principles of human rights, dignity, and safety of individuals. So that's really important to mention that, because as you've said, people can be hurt by the illness, but they can also be hurt by not being treated, and they can also be hurt by discrimination. So these are all really important points. As WHO, we strongly urge individuals, communities, groups, and all countries to consider this a human rights issue as well as a public health issue. So thank you for raising that. From the question regarding severity and the framing of it, this is also a challenge, as it has been, as it always is in infectious diseases. And this one is similar in that regard, is that when people are exposed to infectious agent, they respond in different ways. They respond, sometimes people can be exposed and infected and they deal with it, they don't have any symptoms. And then there are people who have less severe symptoms. They may have, in this case for monkeypox, a few lesions or just a mild fever, and then they get over it and carry on. And then there are always some people especially when it comes to infectious diseases, that actually do develop, for whatever reason, develop more severe conditions, complications. And we're seeing that now. So what we're seeing now is a combination of medical conditions that have been already described in monkeypox, which, as you know, has been known for many, many years now. The first child who was found in 1970. So we're talking over 50 years now. And so the disease on the one hand is well described. On the other hand, the way it's spreading in this global outbreak that has never been seen quite in this way before means that we're seeing new manifestations of illness. And so this includes things that can be extremely painful and need medical care, such as secondary infections or such as inflammation or swelling of the rectum. These are really conditions that require care. But in addition, there can be the occasional conditions such as encephalitis, which is inflammation of the brain, which, as Nika, you've said, we've had reports in the media over the last few days of several deaths due to monkeypox. There had been reports before that have been notified to WHO. These new ones have not yet been officially notified by countries to WHO. It always takes a few days longer. So we can speak to what we're hearing in the media, which is that some people have, a couple of folks have sadly died of encephalitis, and this is very tragic. It's not totally surprising, as I've said. This is how infectious diseases affect people and affect the health of people. So what we're learning right now, we have reached out, as WHO, we reach out to countries and we ask them to provide more information. So as we receive more information, we will share that, of course, with the world. And in the meantime, we can also only go on the media reports that you have. So we do have indication that one or two of those folks may have also had underlying immune compromised conditions, as we've already discussed, and others have not. So that is concerning. But we need to hear more from the clinicians and from the countries where those cases have occurred. And as we do, we will share that information. We will update our messaging, and we will continue to re-emphasize with all community groups and all nations that this is a serious outbreak, and that the reason that the Director General called a public health emergency of international concern is because a response is required. Response is required by WHO, of course, but much more importantly, even response is required by the countries themselves.
So we have, I'm just going to group a few questions. We have Joseph Mukadi, who's asking, where does the disease come from and how to avoid getting it? Hazel is asking, can you share any additional details on transmission? Another question from Tina Sterling, where does it come from? How does one get it? So I think it's worth reiterating, and this happens, it's fine. People join us as we've already touched on something. So just to recap, and Andy, I'll go back to you again. So you talked earlier about it can come through sexual transmission, but that's essentially because when you have sex, you're extremely close to someone and your skin is rubbing up against the other person's skin. And if the person has a lesion, whether or not they know it, somewhere on their body, including in their mouth, they can pass it to someone else. Is there something else you want to add about how this disease passes from one person to another? Because people start to get worried about, do I need to disinfect surfaces in restaurants and public vehicles and so on? And just to reiterate, it is really about a person being very close to another person who has it.
I think that's a critical point, Nika. I think it really is about being exposed to the virus. All of the behaviors that we're talking about happen millions and billions of times all over the world, every day, every second. So there is always somebody holding somebody's hand. People are having sex. People are, caring for people. All of that intimate contact, that close contact, that's happening constantly. And so it really is about having a virus being introduced into a network of people who have a certain type of contact that becomes problematic. So for most people, and it's great that we've got great data. One of the things that we have, we've got a real opportunity because we do have enhanced data coming through, so we're able to understand who and where this is really having an impact. And as we've said, the studies that we're seeing are, 99% male. Of that, 98% of them have reported sexual contact with other men. So again, as you've said, the key thing is that intimacy, the close contact. It doesn't have to be sexual contact, but that's really helped move this virus from person to person. So while, of course, we have to be absolutely alert to all of those other modes of transmission, including, I think Rosamund mentioned that there is a possibility, and we've seen this previously in previously affected countries of West and Central Africa, that households can become, if one person in the household becomes infected, it can be quite easy for that then to transmit to others in the same household, again through just the close physical contact that comes to, with being in a close family. Nothing to do with sex. So it's about just being in that close and intimate environment. So those are the modes of transmission clearly are possible. We're alert to that data. We are seeing cases of women and children that are most likely linked to that level of household contact in the context of this outbreak in newly affected countries. But that doesn't seem then so far it's not going on to other groups. So we're not seeing that then lead to onward transmission through, I don't know, other settings, whether it's schools or workplaces, for example. So the primary context that we continue to look at, we continue to prioritize. Keletso explained perfectly well. I'm going to borrow a lot of Keletso's language when I speak about this in the future, that it would be absolutely homophobic if we weren't to target the resources where we're seeing the infections. We have to be doing more of that. We have to really concentrate on getting the messages out, supporting community groups to further amplify these messages. They're doing great work. It needs to be funded. So we need to support funding for community groups that are increasingly doing this work. And this is because, the communities, obviously they want to protect themselves and their loved ones, but they don't just interact within those communities. People interact with broader communities. So there's an interest in making sure that those that they live and work and socialize with are also protected. Again, the messaging is critical. So at present, we are really seeing sexual contact as the main focus. So clearly that's where we place our main focus. But this doesn't mean that we don't stop also constantly interrogating what's happening with these cases that are outside of that community. It's critical for us to understand when we see what's happening in children and women, to understand so we can control those localized outbreaks that they're so far relatively easy to control, but we just need to be super alert. And again, having this public health emergency of international concern designation allows authorities around the world to really work with us, coordinate and share that information so that we can respond appropriately if we do see this moving into other groups. Thanks, Nika.
Thanks, Andy. We have a question from Dagmar Feddersen, who's asking how many cases there are all over the world. As of today, you can see WHO's dashboard, the numbers that have been reported to us, we share. So there's about 12,000 cases in about 80 countries. There have been 5 deaths in confirmed cases. And as Rosamund was touching on in the media over the past few days, we've heard of perhaps another 5 cases, but I wouldn't add those on yet. We'll follow up and we'll share that once it's confirmed in a few other countries. I want to come back to you, Dr. Makofane. On Facebook, Friedan is saying, what measures are expected to be implemented by health professionals at this stage? And I wanted to touch back on something you were talking about, where health providers might refuse service to people for unjustified reasons. And that happens even in countries where it's more or less accepted that sometimes men have sex with men, and that there are gay people and bisexual people and trans people. There's some, and even in these countries, it can still be a battle, an uphill battle. But what about countries where that understanding is still just happening? What are your thoughts or advice to people who may live in a country where it's not considered okay, it's not acceptable or not recognized at all that there are men who have sex with men and other ways of being with other humans? What's your advice to people who may live in countries and contexts where it's really difficult to be who you are?
Well, I would say that firstly, it's not obvious which context you're talking about, because in the US, there is an all-out attack on transgender children going on at the moment. And this attack, of course, is not only about trans people, but it will involve all kinds of queer people, because the types of people who attack trans children don't make distinctions between the L, the G, the B, and the T. So I think it is a mistake to come into a discussion about homophobia with a presupposition about which countries are homophobic and which countries are not. Having said that, I think if you're in a country where you can access vaccine, you can access treatment, at least in policy, it's very, very important for you to tell people if you think you have monkeypox. We have heard lots of cases in New York City, where I live, where people went to their providers and asked for help, and their providers turned them away. And as a result, those people had to seek services with new providers, which is challenging, just for a number of practical reasons that folks who live in these cities will understand. Your insurance, whether people are taking new patients, whether you can get an appointment, all of those things have been challenges, and have been challenges because the people who are in the system, who are in a position to help, have refused to help. So what is important to do if you think you have monkeypox is to tell someone, tell a friend, tell your parents, tell whoever you trust, try and get your services at your doctor. If you refuse services, go back to the people you told and tell them, I need support, I'm being refused, so that you can get what you need. A lot of people have not been getting what they need because of homophobia. If you live in a country where you have homophobic laws on the books, I don't need to tell you what to do because you're already surviving that. But I think it's likely, if you're living in such a country, that vaccine is also not available at this time, and that treatment might not be available. And in this kind of instance, I would say reach out to, again, speak with your friends, make sure that you're not the only one who knows, so that people can support you. And reach out to your local LGBT community-based organizations and hear from them whether they have providers they can refer you to. So if you've never interacted with it, look it up online, Google LGBT organization in your country, and you'll find one. The final thing I would say is that it's very important for all of us to be acting together globally, which means when we count deaths, we have to count those in Central and West Africa as well. When you talk about how refusing access to vaccine kills people, we have to count the number of people who've died of monkeypox in West and Central Africa. We have to be as connected globally in our talk and our ideas and our political action as we are connected through this pathogen. This pathogen is connecting us across the globe, and the question for all of us is whether we want to only connect on its terms or whether we want to connect on our terms as well. I would like for us to connect on our terms, and I would like for us to build a global coalition, a global movement of people who think it's unfair that some people can have vaccine and some people can't, that think it's unfair that we can have vaccine sitting in a refrigerator, again, literally in a freezer, while people are suffering, and whose suffering could be helped by that vaccine. So wherever you are, there's something that you can do by telling friends and making sure you're supported, and by refusing to be turned away.
Thank you. I'm going to wrap up shortly. We meant to just hold this for half an hour, so I'll come to you, Andy, and then Dr. Makofane for closing thoughts. But Rosamund, Keletso mentioned vaccines again, and we haven't really touched on this, and there have been some questions, obviously, from our viewers asking about vaccines. So what is WHO doing to get vaccine out of freezers into vials and eventually into people's arms?
WHO at present is working with the countries that hold reserves and the manufacturers that produce vaccines. There are different types of vaccines. They have different profiles. Some are produced more recently than others, and there's been a long effort over past 20, 30 years to produce safer vaccines for orthopox virus diseases, which is what we have now. So we have smallpox, for which these vaccines were produced, and monkeypox. Now, these vaccines and treatment products have just come online in the last few years. Because smallpox doesn't exist anymore, it was eradicated by all member states and WHO back in 1980, and then now this monkeypox has been emerging in Africa. It's been there, as you know, as we've been saying, for some time. But the products that are now being used to counter these diseases are actually relatively recent products, the newer versions of these products. And so research is being done to develop them, but now research needs to be done to really determine also how effective they are in different circumstances, in different conditions. There's another discussion happening right now where I was joining just before coming on this discussion, where they are in fact discussing what are the gaps in vaccine knowledge. What do we know about how these vaccines are effective, how effective they are in monkeypox, for example, different types of transmission, different modes of transmission, different circumstances. And so a whole series of studies is being planned. This is not to slow down the rollout. These vaccine studies need to be done at the same time as the rollout. So part of what you were saying, Keletso, about access to treatment, it completely sympathize. Seems to have been really difficult to secure access. some of those requirements have been put there by the regulatory authorities themselves, Food and Drug Administration, Health Canada, European Medicines Agency. They say, well, we have the information we have on these new products. They look good, and so let's use them, but we need more information, and so let's also study them as we're using them. So this is the source of some of the frustrations. I believe some of the countries are beginning to reduce the amount of paperwork that's required in order to access them, and we think that's a really important effort. So that's one avenue, is to reduce the amount of data that needs to be collected around these products. The second avenue is working with manufacturers, not only manufacturers currently producing vaccines, and we have manufacturers in the United States, in Europe, and in Japan, working with these manufacturers, but also with other manufacturers that have already stepped forward to help with some of the putting into vials parts of the process. So we do have this vaccine that is in its sort of what's called a bulk state, but it needs to get into vials, and it needs to get into vials with the right labels for the right destinations. And we have other manufacturers that are stepping up and offering support. So WHO is supporting the coordination around these different activities, and also raising awareness about a really important feature, which is vaccines are not like HIV PrEP. So HIV PrEP is an antiviral, and it can be taken, and it protects you against exposure to viruses. A vaccine generates an immune response, but for your body to produce antibodies and to have the right cells, T cells as well, to respond to an infectious agent, it takes time. It takes several weeks. And so if you're taking the MVA vaccine, which has 3 different names in 3 different places, Jynneos, Imvanex, Imvamune, if it's available where you are, then you also need to be aware that when you take that vaccine, if you're getting the second dose, your peak immunity happens 2 weeks after the second dose. And so taking the vaccine and thinking it works overnight is also, information that is not correct, and that we need to get out the correct information, which is when you take the vaccine, you also need to continue to make safer choices, reduce your contact perhaps with other people while your vaccine is taken. So these are all important messages that will help to accelerate the rollout of the products themselves and get them where they need to go.
I think we've said in other venues as well that or other fora, our leaders have said that absolutely monkeypox has been neglected. WHO has been calling for more research into it, more investment into tools, so that you don't have the vaccine sitting in vats, but they are more available. WHO is working with the manufacturers, with countries who have supplies and so on, to try to get that vaccine out there. But absolutely, we can take it as a global failure that the vaccine wasn't already being used more elsewhere before the problem started to spread more widely. So I'll come to you first, Andy, and then I'll go to Dr. Makofane as well. What are you, especially because you are both at the in Montreal for AIDS 2022, for the big conference that brings together communities and the scientists, and some people are both. Every 2 years. What are you seeing looking forward, Andy? What have you seen and talked about in the last few days that has slightly shifted what you're thinking about the monkeypox response since you first arrived there? And then I'll go to Dr. Makofane for similar.
Thanks so much for the question, Nika. I think, first of all, having these new deaths reported while we've been meeting has been very sobering, but also recognizing what Keletso said earlier, we have to continue to look at previously affected and newly affected countries in exactly the same way and through the same lens. We have to respond to the science. The science will evolve, the data will evolve. And I think we were quite smart at this during COVID to help people understand that messages will change as we learn more, as we find out more data and more science. And monkeypox is no different. We're learning as we go. We're sharing as quickly as we can. This week has been an opportunity for us to strengthen connections and really look at the areas where we need to be prioritizing. Fantastic data shared about enhanced case descriptions coming from the UK. It's critical we get this into all of the protocols that all countries are looking at. It really helps us understand the quite different presentations that we're seeing in clinics well, in this instance in the UK, for example, around that are perhaps more like a sexually transmitted infection. So I think we need to really share that with health workers. Health worker training is another big issue. Keletso also referred to this one. We need health workers to feel safe, trained, protected, and have the skills to interact with communities really in a dignified way. And then I guess the other thing that I'm hearing here is that we really do need to focus more, and I know there are teams already set up to do this, on improving testing. So at the moment, the focus really is on swabbing active lesions. And because of these new presentations that we're seeing, we need to find more efficient ways. Perhaps ultimately, obviously, self-testing would be fantastic. Whether we can ultimately end up with saliva testing, that kind of thing. The testing thing we know in communicable diseases is often the key to everything else really happening. So I think those are the key messages, other than really having communities inform all of our thinking, whether it's around messaging or and prevention approaches, and also informing us about how we approach and learn from some of the access challenges. Access is critical. Communities have been fantastically supportive through HIV over the decades, and so we need to harness that energy. And as you say, Nika, absolutely correctly, a lot of the real energy around this and expertise is around that interface between science and community. And I'm really proud to be able to know many people who really sit within that interface. Some of the community people here have become some of the world's leading scientists on HIV and STIs, and are really working hard to become more skilled around understanding and responding to monkeypox. Thanks.
Thanks. I hope you have a good rest of your conference. Dr. Makofane, what would you like to see next? What would you like to see coming from this conference? What movement would you like to see next in the global response?
Well, I can tell you, let me just, there's an outstanding comment that I wanted to make, that of administrative burden. I think we really underestimate how much is determined by what happens in the clinical encounter, what happens when you go to your doctor, and those 20, 30 minutes, if that you spend with them. We have had an approach to offering treatment for monkeypox. Now remember, for some people, monkeypox is the most painful thing they've ever experienced. They need to be on really strong pain medications. 10% of people in the UK in a recent study who had monkeypox were hospitalized just for pain, 10%. So it's a really painful disease, it's a serious disease. But we've had a system where, in order to put someone on TPOXX, the antiviral that is currently being used to treat monkeypox in complicated or difficult cases, you have to spend 4 to 6 hours filling paperwork as a clinician, which means that you cannot treat 10, 15, 20 people in one day and submit their paperwork in time. And it also means that some providers say, I'm not going to be paid for the 4 hours I'm going to spend to fill out your form, so you will have to find this medication elsewhere. So these frictions that happen in the clinical encounter have really, really shaped how people are able to access care, including just care to manage their extreme pain. So I think we shouldn't underestimate, when we say there's an administrative burden, I just wanted to clarify that I'm talking about a huge disruption in how any clinical service would be running, and a disruption that is created by regulation, a disruption that we have some control over. And the question is, why aren't we acting with the urgency to make sure that those disruptions are not there and that it's as easy as possible to get care? I should just say that I'm in Canada, I'm in Montreal. In Montreal, many, it's embarrassing, it's scandalous. Many scientists who come from rich countries and are gay men have their first monkeypox shot here in Montreal. You can go to a service, it takes 20, 30 minutes from the beginning to the time you get your shot, and then maybe another 10 minutes waiting to make sure you don't have an allergic reaction. It's possible to do. There are places where it's being done. The question is, why isn't it being done in some other places, including the place that I live, the United States? What I want to see come out of the conference is a global solidarity. It is a response to this outbreak, this epidemic. Maybe we should just accept that we failed enough for it to move from an outbreak to an epidemic. So we need a coordinated response for this epidemic, and we need for that response to be funded and for that response to distribute goods equitably. At this point, the US owns almost all the vaccine that is being used to prevent monkeypox. So the question for people who are US citizens and who are interested in global citizens is, if you believe that humans are equal, if you believe that all of our pain is the same, if you believe that race is made up, countries are made up, then how can you be in a situation where only Americans can avoid that kind of pain, as if Nigerians don't experience pain? It is a real moral problem that I think US citizens have to face. The rest of us have to figure out how to organize ourselves in order to ensure that the fact that we live in a global capitalist society does not prevent us from enjoying our bodies, enjoying our lives. We are, as humans, we have been on this planet much longer than the current system we have for giving medicine and giving food and giving housing. And I think we need to be serious about asking ourselves, how can the difference between avoiding pain and having a nice life or not be just because you were born in the US or you were born in Nigeria or you were born in another country in Central Africa? It doesn't make sense as a justification for the difference in experiences, the difference in suffering. What I hope for and what I know will happen, because activists have been meeting during this conference, is that coming out of it, we will, it's a good signal that the World Health Organization has given the public health emergency of international concern. We will use that to advocate, to build structures, build a response that will help us for monkeypox and help us for all the other epidemics that are coming. Part of the problem here is that COVID happened, and we have been talking a lot about pandemic preparedness, and we expect for there to be more epidemics of infectious disease coming. So, and if we fail so terribly at an illness which fortunately is not killing people as much as it could in the Western world, fortunately, right? It is in Central and West Africa, but of course, we don't want anyone to die. So we have this new epidemic. I mean, it's the same path. It's a pathogen that's not new, but the way it's showing up in the population is new. So let's think about it as a new outbreak. And we have tested the systems that we think we put in place after COVID or during COVID in order to respond to the next thing coming. And that has completely failed. And I think if we don't internalize that, if we're not serious about understanding that and using it to create better structures, better systems that will help us in the future, we are setting ourselves up for more pain and more suffering in the future, because we know that monkeypox is not the last surprise we will see in our lifetimes. There will be others to come.
Thank you. So we've come to the end of our time. There are many questions we didn't answer, but some of them we did towards the beginning. There were questions later about the deaths and how those happened. There's questions about prevention and so on. If you want to just rewatch, you'll be able to see answers to some of those questions. And people have joined us today from Rwanda, Brazil, the US, the UK, Mauritania, India, Iran, Niger, France, South Africa, Albania, Uganda, Ghana, Israel, Yemen, Pakistan, Nigeria, Turkey, Ethiopia, Oman, Gabon, Peru, Colombia, Saudi Arabia, and so on. So thank you so much for joining us today. Thank you for joining us each time we do these lives. Drop in a comment to tell us if there's other information you're missing, what other things you'd like to hear about on monkeypox. Thank you all for being with us. I'll just go around one more time. We had with us today from WHO, Dr. Rosamund Lewis, who's our lead for monkeypox. We had Andy Seale, who's a WHO expert in HIV, hepatitis, and sexually transmitted infections, and Dr. Keletso Makofane, who you heard from at the end, who's a fellow at the FXB Center for Health and Human Rights at Harvard University, and a public health researcher and activist who works on the global HIV response. Thank you all, and have a good rest of your conference for the two of you in Montreal. Bye-bye.
Thank you.
Bye. Thank you.
Bye-bye.